We are just done with the bradyarrhythmias. Now let's see about the tachyarrhythmias. The tachyarrhythmias are mainly of two types, the supraventricular and the ventricular. First, let's see the supraventricular tachyarrhythmias, and the first one is atrial fibrillation. Atrial fibrillation, tachyarrhythmia, as the name suggests, we note that the heartbeat is going to be high. So the patient has palpitations, tachycardia, and chest pain, and the patient will have dyspnea, diminished exertional capacity, and occasionally syncope. This is because the heart is pumping so fast, but the cardiac output is not given properly. The heart is just trying to run, but it is not producing enough amount of blood. This atrial fibrillation can cause clots and can lead to thromboembolism, commonly seen in stroke patients, that is the cardioembolic stroke. There will be atrial fibrillation, then there will be formation of clots, and that clots would be dislodged and go and block in the circle of Willis or anywhere in the cerebral circulation, causing stroke. That is the cardioembolic stroke. And this atrial fibrillation is the most common arrhythmia. If you see the ECG findings, there will be a heart rate of more than 300. The rhythm is irregular, and the P waves are absent, and the QRS is narrow. The treatment for these patients are beta blockers or calcium channel blockers to decrease the heart rate. Previously, we saw that in the bradyarrhythmias, the patients would be using beta blockers or calcium channel blockers for any other reason, and they would develop a decrease in heart rate causing bradyarrhythmia. But now these patients having tachyarrhythmia, we are giving beta blockers or calcium channel blockers therapeutically to decrease the heart rate. And when the patient is very unstable, we can give a DC shock. Then, since these patients have thromboembolism, we also are required to give the anticoagulants. If you see the ECG paper about the atrial fibrillation, you can calculate the heart rate that is more than 300. And how to calculate the heart rate? Everything I have explained in the ECG physiology video. You can kindly check it there. And the rhythm is irregularly irregular. Now what does it mean, irregularly irregular? If the rhythm is regularly irregular, that means there is some abnormality in the rhythm, but that abnormality has a proper fashion. For example, it will be like one R wave and two boxes empty, then again one R wave, then one box empty, then one R wave. Then again this pattern would repeat, one R wave, two boxes empty, one R wave and the other R wave. This is regularly regular. But if irregularly irregular, there is a problem or abnormality in the ECG, but that abnormality does not have a regular orderly fashion. It will be just haphazardly arranged, irregularly irregular. And the P waves are absent here, as you can see. And the QRS is narrow. Most of the supraventricular tachyarrhythmias would have narrow QRS. Then if next one is atrial flutter. And the next one we are going to talk about is the atrial flutter. Now, after seeing the atrial fibrillation, what is this atrial flutter? In the atrial flutter, we can see the patient again having the same symptoms, and the patient can also produce thromboembolism in this. The ECG findings are more than 250 beats per minute. The rhythm can be variable, that it can be regular or irregular. There is a characteristic finding, that is the sawtooth pattern in atrial flutter. Now the QRS is narrow here, as I said, for all the supraventricular tachyarrhythmias. The treatment here is again to give beta blockers or calcium channel blockers, and if the patient is unstable, the patient would require a DC shock. The ECG findings in atrial flutter, if you see the heart rate is more than 250, the rhythm can be regular or irregular, and there is this characteristic sawtooth pattern, and again the QRS is narrow. Then next see multifocal atrial tachycardia. These patients usually will have a history of lung disease like COPD. So if your question says a COPD patient is developing an arrhythmia, you should first think about this one. The patient's ECG findings would be heart rate of 100 to 150, and the rhythm is irregular rhythm. The P waves is present but has different morphologies. If you see here the P waves and this P waves, there is a difference in the morphology. And see this P wave, they are different in the shapes and sizes, that is different morphology. The QRS is narrow. Here an important thing to be noted is the isoelectric line is maintained. As we saw in the atrial flutter, there was a sawtooth pattern, so there was no isoelectric line, but here the isoelectric line is maintained in multifocal atrial tachycardia. The treatment here is calcium channel blockers, preferably verapamil, to decrease the heart rate. DC shock is not useful here, as mainly we have to treat the underlying causes, that is for underlying causes like COPD. The amiodarone can also be used here. This is an antiarrhythmic drug. Now let's see about PsvT and AVNRT. PsvT is paroxysmal supraventricular tachycardia, also called as AV nodal reentrant tachycardia. The patient is usually a middle-aged female here, and she is asymptomatic. The ECG findings to be seen here are, there are hidden P waves. P waves are present, but they are just overlapping so that we cannot see it. The QRS is again narrow, and there is ST depression. If you see here, there is some ST depression here. This elevated one is the T wave, but the one going like this is the ST depression. It is like this, and there is an elevated T wave. And there are pseudo S waves in lead 2. If you see here, the waves are like this, and they have a small wave, that is the pseudo S wave seen in lead 2, and pseudo R waves are seen in lead V1. In V1, usually the complex is not in this fashion. The R wave points downwards because of the placement of V1, as said in the ECG physiology video. But in this V1, you can see the R wave pointing towards upwards. So this is a pseudo R wave seen in lead V1, seen in PsvT or AVNRT. The treatment for this is first to give the vagal maneuvers like the carotid sinus massage, and then we give IV adenosine, that is the drug of choice for these cases, and then we can do a DC shock if the patient is unstable. Then let's talk about the ventricular arrhythmias. The first one is the ventricular tachycardia. These patients also have palpitations, dizziness, excess intolerance, episodes of lightheadedness, syncope, or even can have sudden death. This arrhythmia is seen mostly in the post-MI patients. a patient would develop a myocardial infarction, and then later he could develop ventricular tachycardia, which can cause his death. There are two types of VTs, that is monomorphic VT and polymorphic VT. And there is a special term here, VT storm. What is a VT storm? VT storm or the electrical storm refers to 3 or more separate episodes of ventricular tachycardia within 24 hours. In a single day, the patient would have 3 or more episodes of ventricular tachycardia. That is VT storm. Now let's see the types of VT. In the monomorphic VT, these are usually seen in tetralogy of Fallot patients, the congenital heart disease. Those patients could have monomorphic VT. And in the ECG findings, here we can see wide QRS resembling each other. And then there are P waves, but those P waves are hidden, so we cannot appreciate it. And then the Josephson sign. If you see here, there is a small depression here, or a small notch. This small notch is the Josephson sign. Josephson sign is seen in ventricular tachycardia, monomorphic VT. And then for the treatment, if the patient is stable, we try to give medical management like the amiodarone antiarrhythmics. And if it's a post-MI ventricular tachycardia, the lignocaine is preferred. If the patient is unstable, give a DC shock, and we can also use implantable cardioverter defibrillator, as these cases are very serious. And then we will see about the polymorphic VT, or also called as Tossat's D points. These patients are usually associated with Brugada syndrome. And the ECG findings are wide QRS with beat to beat variability. The QRS is wide, but they do not resemble each other. That is what it means, beat to beat variability. And the QT interval prolongation can trigger ventricular tachycardia. The treatment here is to give MgSO4, magnesium sulfate, if the patient is stable, but if the patient is unstable, we go for a DC shock. We can also give ICTs, implantable cardioverter defibrillator. So you have to differentiate the monomorphic VT and the polymorphic VT. You can easily differentiate with the beat to beat variability and it being the same. And then let's see about the ventricular fibrillation. Just with the same symptoms, the patients of VT cannot progress to ventricular fibrillation. The ECG findings here are again irregular pattern. There are no identifiable waves, and it is called as coarse or fine chaotic undulations. These are undulations, they are very coarse. The treatment here is amiodarone, DC shocks, and ICTs. So it is very important to differentiate the ECG of monomorphic VT, polymorphic VT, and the ventricular fibrillation, as all the threes may resemble same in when you are very tensed in an exam situation. So in monomorphic VT, you can see the same waves. In polymorphic VT, there is beat to beat variability. In ventricular fibrillation, these are irregular, no identifiable pattern, and coarse or fine chaotic undulations. If you see here, just in one lead, there are big waves, small waves, medium waves, again big waves. It's very unidentifiable. This is ventricular fibrillation.